Well, good evening, everybody, and welcome to yet another ISR online event. This is our ISR Knowledge Exchange series, and it's brought to you this evening in partnership with Migration Network Northwest, also based at Edge Hill University and Wirral Change. My name is Jo Crotty, and I'm Professor of Management and Director of the Institute for Social Responsibility, or ISR, at Edge Hill University. ISR was formed in 2019 to engage in socially responsible research and knowledge exchange across all disciplines. I'm therefore delighted this evening that we can support this event, looking at the critical issue of communicating health messages in what might be described as hard to reach groups or hard to reach areas. Shining a light on the underreported, excluded, marginalised, or the hard to reach, particularly in our region, is at the centre of what we do. By hosting this event this evening, we're hoping that we can exchange knowledge on effective communication in these contexts, both by conveying the message and hearing the response. So without further ado, I will hand over to Ruxandra. She's our ISR Fellow for this year and reader in the Department of Creative Arts, who will be facilitating this evening. Over to you, Ruxandra.
Thank you, Jo. Hello, everybody. Good to see you here, and thank you for coming. As Jo said, I'm Ruxandra Trandafoiu. I'll start by saying a little bit what motivated this event. I think the COVID-19 pandemic has exposed a number of health inequalities, as we know. But these inequalities also reveal the failure or partial failure of public health communication. So in this knowledge exchange event today, we want to focus on the Wirral Peninsula, an area defined by high mobility that has undergone significant demographic change and ethnic diversification over the last decade. Our aim being to understand the cultural, economic, or political motivations and barriers experienced by various ethnic minority groups that prevent them from fully engaging with health-related programs and communicated health risks. So our speakers tonight will attempt to answer a number of questions, such as how do migrant and minority populations engage with public health messages, what additional risks emerge during health crises, what are the specific challenges of the Wirral Peninsula as a space of transit, mobility, and resettlement, and how can local government and health practitioners address these risks and challenges and communicate more effectively. This event is part of a longer project that we are kickstarting tonight. And we welcome any questions and comments from you in the chat. We will try to respond to them tonight and also engage with them in our future research on these issues. So without further ado, I would like to invite Clint Agard, who's the CEO of Wirral Change, one of our partners and collaborators on this project, to talk about the specific challenges that his organization has faced in relation to health communication.
Hi, my name's, good evening everyone. My name is Clint Agard. I'm the Chief Executive Officer and co-founder of Wirral Change. So I will talk to you, give you a brief on some of the stuff some of the issues that Wirral Change and Wirral Change's staff go through, and the clients and the clients face on a daily basis. It will be a brief insight. As Ruxandra says, if you've got any questions, if you could place them in the chat, and so Ruxandra can manage that on our behalf. I'll go right into it. So Wirral Change, we are a Black Asian minority ethnic organization that was founded 15 years ago. We started off in employment, and it was around breaking barriers down to enable our client group to go to mainstream and use mainstream services. So initially we were the bridge, if you like, in the Wirral. And back then, 15 years ago, the racial makeup of the Wirral wasn't the same as it is today. So over the years, we've worked tirelessly with local strategic partners, setting up new initiatives to engage our client group better, but at the same time trying to maintain a sense of community. One of the things that I pride myself, or the organisation prides itself on, is the fact that we've got into local community, BAME communities, and got our staff from those communities, trained them appropriately in, healthcare, give them IAG, information, advice and guidance, training at the highest levels, translation and interpretation qualifications, and things like that, so that they can better engage with the community groups that we serve. Our specialities in engagement, we've polished them over the years and developed them and made them much better, so we could build better trust from our communities, so that we could be the voice for those communities, and helping them to get services that meet their needs and cultural needs. So over the 15 years that we've been working with these community groups in the Wirral, we've seen remarkable diverse change within those groups. When we first started, we have a long-standing Chinese community, which is still probably the biggest racial minority group in the Wirral, and definitely the oldest minority group in the Wirral. But our Europeans, particularly the Polish, and are now almost as big, as well as the Bangladeshi community. They're almost as big. We have a growing Arabic community as well, and we now have a growing Romanian stroke Roma community that is growing fastly in the Wirral. So as well as other community groups, we have the African different African community groups that are growing, because the Wirral is now a dispersal area, so we get a lot of asylum seekers and refugees that are placed in the area as well now. So it's very diverse in culture and race now in the Wirral, and we know that there's at least 35,000 diverse BAME cultures and racial people here in the Wirral. It's a term that I really don't like to use, but I'll use it for this purpose. We do recognise that there are hidden communities, and what I mean by that is there's communities that, because of some of the inequalities that exist within the Wirral around certain social services and health services, those community groups are difficult to engage with, but we encourage, we get out there and we partner up with some of our other agencies to help us develop and work with that. So some of the issues that we're facing, translation, unbelievable. Translation is still one of the biggest issues that we have here in the Wirral, as we do, as it is in other parts of the country, and it never ceases to surprise me that it exists. What I will say is, during the pandemic, the translation situation almost overnight became much better. It has always been a huge inequality barrier within the BAME communities, with literature often going out that people who can't speak or read English couldn't read it, and now we've been getting an influx of different languages coming from directly from Home Office, Public Health, and other strategic partners. The context of things often doesn't mean anything to the community groups that we serve, because it's often catered to a white British audience. So our people, our community groups will look at that and think, well, it doesn't mean nothing to me, I don't need it, you know, because a lot of it, a lot of the stuff we have to use, or we do use, is stuff that is literature, videos, and stuff like that. And we have been getting over that, not just during the pandemic, by the way. We've been getting over that for years by using our communities to explain things in videos and in on audio in different languages. Very low literacy, and with our community groups. And like I was saying, so difficult has been so difficult in the past to get things translated. Hence the reason Wirral Change purposely went out and got people from the communities, developed them, trained them, and to enable us to use people from their own communities to help them engage better with services. So some of the interventions that we would really like to see, and the research needs to be updated. Often there is some good pieces of research that is conducted, and we find it tends to get put on a shelf. 2 years later, they come back to do more or less the same thing again. Why can't we revisit it quarterly and look at things to bring them up to date? And that's not just about COVID. I think what COVID has done has highlighted how much we're going to need to update information on a regular basis around BAME communities. I think that's been evident throughout the pandemic. services that are thoughtfully designed. And what we mean by that is look at let's look at together. Let's look at the BAME communities. Let's look at some of the let's have cross-cultural consultations. Let's do this together so that we can seriously think and design the right type of services for BAME communities, and let's be more consistent. Let's try to be more consistent, and this all comes down to keeping our research up to date, being more informative, not being scared of being more informative in doing research, working closer together so that things aren't just a flash in the pan thing. And this is an example of Wirral Change, working closely with strategic partners, local GPs, and this is Wirral Change doing the vaccination with the communities. We now deliver, well, not deliver, we host vaccinations within the centre here. My staff will go out, inform people on the advantages of having the jab, the vaccination, and why it's needed, how that will help them and their families. We target generational households. We have plenty of generational households here in the Wirral, so we purposely target those. Sometimes, just to add, I forgot to mention this, sometimes doctors, GPs can be the problem. We found in the past that they can gatekeep on the patient's clients, if you like, not letting you know, not letting you in the surgery. But the more you persist and insisting on working with them, then they tend to drop their guard a bit and realise that that's what we found as an organisation. Realise that you mean well and you've got the client stroke patient at heart. If there's any questions, please put them in the chat, and Ruxandra will get back to me or answer them. Thank you for listening.
Thank you very much, Clint. It was good to hear some accounts from the field and some of the challenges that Wirral Change and other organizations like yours have had to face, and also the importance of intermediaries like Wirral Change to allow a better link between service users and service providers. I would like now to invite our second speaker before we open this up to some discussion. Our second speaker is Edna Bompong. She's Director of Communications and Engagement for Shropshire, Telford and Wrekin CCJ and Integrated Care System. Edna will be talking about a piece of research that she coordinated for Cheshire and Merseyside that has tried to address some of the issues that Clint was talking about.
Thank you very much, and I'm delighted to be here. So yes, I'm going to talk just very briefly about a piece of research that we did, some insight research, which actually looked at the impact of COVID on ethnic minorities in Cheshire and Merseyside. So I, at the time, was the Director of Communications for the Cheshire and Merseyside Health and Care Partnership. I now work in a different system. Just very briefly, because I don't think we need to dwell on this too much, because I think everyone is really clear, and we know that COVID-19 was disproportionately impacting some groups of people. Now, a lot of the inequalities that existed was replicated apart in terms of mortality rates, apart from on ethnic groups. So there was a real issue that we could see that people from Black and minority ethnic groups were being impacted more so from COVID. And I don't need to go over that, because I'm sure everyone's aware. But at the time, you know, back in, so it was probably about August last year, I was saying, you know, we can see this is happening. We can see that there's already inequalities that exist. And unless we get a better understanding of some of the ethnic minority community, actually the gap's going to widen. We also could see that there has been a significant decrease in people accessing NHS services for a range of conditions that were not related to COVID. And again, disproportionately, that seems to be people from ethnic minority groups. So I'm going to canter through some research, the research that we did, but I will show a link at the end of this, which will enable you to access all of the packs, all of the reports, anything you want. Plus, if there's any additional questions, happy to answer that. But just be aware, this is going to be a quick whistle-stop tour of a piece of work that was about 6 months, took us about 6 months. So again, briefly, the purpose of the research was about understanding the impact of COVID-19 on different ethnicity groups in terms of, you know, the fear factor, how they're accessing services, and also very importantly, one of the things that was very pertinent at the time, and we were the first area to do this, was to look at how this group were, what their views and attitudes were towards the COVID vaccination programme, because we knew that that was going to be important to understand. And what we wanted to do was understand all of that and then use that insight to look at how we would engage with these communities in a way that resonated and was relevant and purposeful. But also it was about how do we design services now and interventions that are right and relevant for these groups, because we recognise that how people are, the impact that people have had to COVID would also impact their propensity to recover. So we need to understand what these impacts were in order to kind of look at any recovery strategies. So again, I won't talk you through this too much, but we did, as I say, this was quite robust. We did it in 3 phases. The first phase was about understanding who our ethnic groups were, because what we use all the time in public health and in the public sector is quite outdated data, the census data, because that's all we've got. So we created a model which would give us a better, refreshed view of our ethnic populations across Cheshire and Merseyside. We then, phase 2, we engaged with over 600 people from different groups, and we managed to talk to every single ethnicity group across Cheshire and Mersey. And it was quite a detailed survey or questionnaire that we asked people. So that was, I always say, the quantitative data research gives us the who, the what, and the where. But once we'd done that, we wanted then to find out the why. So why do people feel this way? What is it? Let's get under the skin a little bit more. So we then did a range of detailed focus groups and in-depth interviews to actually get a little bit more of an understanding. And most of this, what I'm going to feed back to you, is kind of a culmination of the phase 2 and phase 3. But as I say, it's just the tip of the iceberg. So one of the first things that we discovered, which was quite interesting, was that trust in the NHS was much higher than in the government. And when I say the government, that is local governments, so our councils, but also national government. And when I say trust is much higher, that means that when they received information, or when there was information related to COVID that came from government sources, they were less likely to believe it. So you can see here, I've just pulled out this one slide, which shows that 14% of people did not trust the information received from national government, and a further 25% did not take it on face value and wanted to check it. Now, I think that's quite important, and it's important for me from a comms point of view. So it made that when we were doing campaigns and things like that, I would make sure that we badged it as an NHS campaign as opposed to a local authority or a national government campaign, because actually for this particular group of people, they're more likely to trust it if it comes from the NHS. The other thing that we discovered was that that the access to health services have declined. So COVID had such a major impact on access to healthcare amongst ethnic group, with about 70% of them saying that they did not access a health service in the last 6 months. But they needed to access one health service, but they didn't as a result of COVID. Now, most of that was in relation to dentist services, as well as opticians, GPs, and hospital appointments. Now, that's quite a problem for us, because that means that we know people from ethnic communities quite often can have multiple and complex needs, and actually they're not accessing the healthcare that they require. Now, we'll come back to the reasons why they might not be accessing these services. A note that was very interesting was that almost a quarter of the population that we spoke to believed that they had had COVID, but only 10% had actually had a COVID test. Now, a lot of that was put down to, well, that's because people in certain groups do certain jobs where they can't take time off to go and get tested. But actually, our research showed us it was a little bit deeper than that. Some of it was because of people not trusting the government about how they would use their data. Kind of that nanny state thing, like, what are you going to be using with this? Where's this information of mine going? So real issues about trust, and we'll talk a little bit about that in a moment. The acceptance of vaccine was lower in deprived areas. There was a real correlation between when we looked at our uptake figures. There was people in deprived communities, where often our ethnic minorities lived, were less likely to be accepting of the vaccine. But that wasn't only true to people from ethnic minorities. That correlation is for people from white backgrounds as well. In terms of the COVID vaccine take-up, there were lots of issues about reasons why people did not want to take the vaccine. Some of that was, and much of that was about things like potential side effects, but they were real big concerns from people. But there are other concerns as well. There were other concerns that were kind of functional, like people that were scared to actually leave the house and take and actually get the vaccine. But there were other things like not trusting the government. Again, they didn't believe what the government was telling them. And some of that is to do with, for years and years and years, this group of people have felt disenfranchised, felt like they've been let down by the government, felt like the government has never put them first. So then they were suspicious. Well, why are you now telling me that I should come and get this vaccine now, and I should be in the front of the queue? There was lots of trust issues around that, and you can understand why from past experience. We also know that COVID has had a major impact on mental health. So when we ask the question about how people's health has been impacted through COVID, all aspects of health have declined remarkably for a large proportion of the respondents. But over half, 54%, had seen a deterioration in what we classed as their emotional well-being, with a fifth, 20%, stating that it was a lot worse than before COVID, and that's quite an issue, I think, and it's an issue because we also know that people from ethnic minority groups are less likely to also access mental health services. So now, as I say, that's just the tip of the iceberg of some of the findings. But I've just got one slide really to talk through some of the recommendations and some of the things that we feel that need to be addressed given some of the insight that we've gathered. Trust. Real concerns around trust. Some of the concerns stem from experiences of health and care, but a lot of it are feelings of disenfranchised, feeling let down. So the NHS and the government really need to build trust in general, but not just in relation to the vaccine, not just to get people to take the vaccine, but as an ongoing programme of how do we get people from ethnic minority to engage with our services more, engage with messages more. We need to build that trust so they trust what we are saying. We also need to acknowledge that they have some genuine concerns. And let's not call people that don't want to be vaccinated anti-vaxxers, because actually that's not necessarily the case. And let's really address, let's acknowledge that there are real concerns about why some of these will not have the trust that they possibly should in the government or public health messaging. In terms of our communications, there is something about being authentic and relevant, so using real people. Now, I know that we can often think that using sports people and famous people is a way of engaging with communities. Now, it can be in the right circumstances, but actually people that look like them, sound like them, are from their communities, are much more likely to have that traction and impact with these groups. There's something about being positive, no scaremongering, not being threatening, because actually that just builds fear and it turns people away. Simple tone, easy to understand. Now, Clint spoke a little bit previously about translation. Now, in my experience, I think that we did a lot of translating for for the survey when we first put it out, because we were asked to by a lot of our communities. And what we found that was the only translation that seemed to really be of use was Chinese. Now, what we found was a lot of people in certain communities, they can speak their language, but they can't necessarily read it. So quite often you have to ask yourself, do we need to translate this, or do we just need to put this in a simpler tone, in something that's easy to understand in easier English? And actually, do we need to use different sources like videos and things like that where people are speaking in mother tongue? I think that has much more traction. And to be honest, from a comms person, where I know that translating is so expensive and we have so many different languages, I think that sometimes in the public sector, we kind of make the wrong call with translating a lot. I think there's different ways of doing it, and actually maybe it's certain communities that we do need to translate for. Mental health is a big issue. We need to provide more culturally relevant services. So I will use my example as my sister, who has mental health issues, who is Christian, and we are African. She will not go to speak to a mental health services that doesn't understand her faith, because her faith is what I believe drives a lot of her mental health issues. But also in Africa, we believe in black magic. And actually, you need someone who understands that point of view to actually be able to talk to you and give you the right advice. So actually, there's something about cultural and relevant services that are really going to get people to engage. There is also something about people recognising that the NHS isn't only for physical health. They can access the NHS for mental health as well, because within that community, I don't think it's as widely known. But also there's something about breaking the barriers down, that people recognise that it's okay to talk outside of your family home or outside of your community, because I know I was grown up to be told you don't air your dirty linen outside. So actually talking about your problems was a no-no. And lastly, the role of GP. Now, we know over the last year that we have some real concerns that people are telling us about accessing GP services. However, trust is still very high within this group. GPs are well trusted, and we need to do more about supporting them to understand their role, the role that they can play in actually engaging with some of these hard to reach groups. And lastly, there is something about also educating some of these communities that all roads do not necessarily lead to GPs, because there are other ways of accessing primary care that doesn't mean going through your GP. So that is me. That is a very quick whistle-stop overview. I hope you have found it useful.
That was great. And also great to see that some of the things Clint and you were talking about are quite similar. The issue of trust, the importance of GPs, and GPs acting sometimes as gatekeepers. Also the importance of politics emerges from some of the comments in the chat as well. So I would like to invite my colleague Paula Keaveney, who is a former PR practitioner and current program leader for the politics degree here at Edge Hill, to respond to some of the issues that emerge from the talks. And then I've also got a couple of questions.
Yeah, they were both so interesting, those talks, and I've almost got cramped from writing things down, but a few points did occur to me, and some of them are more in a question format than anything else. So we talk about access to primary health care and some of the barriers there may be, but I wonder if more could be done with community pharmacies. So if you think about it, community pharmacies, they're shops, they're places you would walk past to go and buy things, so they feel a lot more accessible than a GP surgery. They may not, in fact, be more accessible, but they feel like it's less of a problem to pop into a pharmacy than to make an appointment with a GP. So perhaps it would be interesting to explore that. And I also think in health communications and all communications, there's often this thing called the frequently asked questions, or the Q&A sheet. And sometimes the question you really need the answer to is not there, because it's so very basic that no one's thought to write it down. And I'll give you an example which is relevant to health. I went to have my 2 vaccines recently, and I made a point of thinking what to wear. And the reason for this is I had no idea how screened off the vaccination area would be, whether there'd be people walking past. And I didn't particularly want to strip off in St Helens Rugby League Club, which was where I was going. And I couldn't find anything in the information which told me how much privacy there would be for the vaccinations. Now, actually, at the end of the day, I would have just stripped off if I had to. But there probably are people, and there may well be people in the BAME community who would be concerned to know that before going for the vaccination. And by not having that information very explicit, and in fact, by featuring on the television a lot of male politicians stripping off, we're effectively, I think, putting up a barrier to those people who for whom that would be a concern. So I think maybe looking at the frequently asked questions with the mindset of, hang on a minute, if I literally knew nothing about this, apart from what I've seen on telly and my assumption of what this church hall is like, what would I need to know? And it's almost like everybody doing the comms needs to perhaps take a step back and think, what are those really, really, really basic things? So 2 points there about pharmacies and also about FAQs. But I also think there's a huge issue about delivery mechanisms for health communications. And this point was made really, really strongly by the 2 speakers. But I think one of the I've stopped reading the news recently because it's just so contradictory. And I think if what we're seeing is nothing but contradictory messaging, which changes on an hourly basis on some websites, you're going to lose trust, aren't you? Because I can't tell you who's on the bloody red list now, you know, for example, and I don't care about traveling. So, but if you're caring about your health and you still see all these contradictory messages, you are going to lose trust. So there's a key thing there about the delivery mechanisms we have that can overcome this sort of media confusion. So those are my 3 points, and they're 3 questions rather than solutions, but they're probably the sorts of things we'll want to pursue in the research.
Yes, I think so. Just briefly, Paula, what do you think of this tendency to use celebrities to try and reach communities when it comes to health messages? You know, as a former PR practitioner and lecturer, you know, what's your opinion?
Well, I think they can be useful. So at times, you know, if your hero is a football player, so if it's maybe young men in deprived areas who love football, actually using a football player might be really, really good there. But on the whole, I don't care if some famous person's having their jab. And I think certain people like the royal family have a responsibility to say they've had their jab, but that's different from persuading people to have it done. And, you know, there's 2 things you can do. You can use a very famous person, or you can use someone like me. And I think if it's in terms of receiving a service that's going to help you, the someone like me is better than the famous person.
Yes, indeed. Edna and Clint, something occurred to me while I was listening to your presentations. I don't know if you can respond to this, but to me, the NHS is one of the more diverse organizations in the UK. Certainly a lot of GPs come from an ethnic minority background. So how come do you think there is a disconnect then between local communities and their GPs, who should be representatives of those communities because of the diversity that exists in the NHS? Because both of you, you know, you were talking about the importance of GPs and access to care through GPs.
So when you say disconnect between GPs and the communities,
well, I was thinking of what Clint mentioned, the fact that sometimes, you know, people go and they don't know what to ask for, but the GPs obviously could refer you or could give you a voucher, you know, to access Slimming World, for example, or things like that, but they're not sort of forthcoming sometimes. And, you know, there is trust, as you pointed out, in the NHS. But sometimes also some of the communication that comes from doctors can be quite specialist, isn't it?
Yeah, so I think there's a number of things. So your first point about the NHS being quite diverse, it is to a certain extent, but I mean, don't get me started on what that in seniority point from perceptions. I think there's lots of evidence about how undiverse the NHS is at quite a senior level, and some of the decision makers, and that is part of the problem, because you don't have the decision makers who represent their communities. Actually, services and things like that are not delivered in the right way for those communities. So that's one thing. I think in terms of GPs, I think what we've got to understand is our GPs are, especially at the moment, extremely overworked. We've got our GPs who have been running the vaccination programme, as well as trying to do the business as usual stuff, as well as trying to adapt to a new way of working and a new way of seeing patients, because actually that's what we've all had to do. So I think that the challenge is that they are trying their best, but actually, especially GPs that are working in areas that have got a high ethnic minority populations, what you often find is that, as I mentioned before, is that those people have got complex needs, so multiple long-term conditions and things like that. So actually, where you've got, so therefore, and they quite often have big patient lists. So where you've got GPs that have roughly about 8 minutes per patient, you can see how that's going to be quite tricky if someone walks through the door with a number of different complex needs, and you need to try and support that person, plus get your paperwork done and all the rest of it within a really short amount of time. So there is a range of issues. I think that there is some of that connection to community. So I know that it was my mum's GP that made her, and I say made her have the COVID vaccine, because that's exactly what it was. She didn't want it, but her GP basically phoned her, and when she was in there seeing him about her blood pressure, he literally stuck a needle in her arm and was like, "You're having it, Mrs. Bompog." So this isn't about bashing GPs, because I think that GPs are do extremely well in the tough conditions that they have at the moment.
Clint, do you want to?
Yeah, I would agree with all of that, actually, and what I would add when looking at the Wirral, all the things that Edna said about how busy GPs are, or maybe in high proportioned BAME areas, and the difficulties that they have in managing that. But you've got to look at it where the Wirral's concerned. You've got to look at it. We are the minority here. We aren't a high proportioned BAME area. So when that BAME patient walks into the busy doctor's surgery, and they are busy at the moment, all the things Edna says I agree with, the different way of working now, the complex issues that walk through his surgery, all those things, and then a BAME individual comes in with additional barriers and issues and stuff for the doctor to deal with in a predominantly, and they are the minority in that area. There's then more difficulties. I think the NHS, I agree completely with Edna again with the structural stuff. If she started on it, we'd probably both be on it for quite some time, so let's not go there. However, what I would say is, one thing I would say is, I think the NHS are missing a huge trick. I just can't get my head around it, because you're right. Nationally, locally, even here in the Wirral, they have the most multiracial workforce that there is, and they don't utilize it in any sense of the word. And that's right at the top, middle management. They just do not utilize it at all. And they could save themselves a lot of money by training certain staff. And when I say staff, nurses that are on wards, people like that in certain areas, like translation and interpretation, so that they have the qualification, which doesn't cost an arm and a leg, and would save them huge amounts of money if they had on-ward interpreters and translators that were nurses and doctors that were qualified or had their national qualification to do that. So there's a lot of ways that they can help resolve some of the inequalities that have been there since Wirral Change has been existent and are still there now.
Yeah, thanks for that. I had another question that it's related to both your talks, and that is around faith and community groups. Now, I know they're quite important because obviously to target certain groups, you need to go through those people in those communities that have visibility and people trust and so on and so forth. But in relation to what Edna was saying about her sister, isn't there a danger in maybe relying too much on some of these faith groups? Because sometimes second-generation migrants or younger people from ethnic minority groups don't engage with faith institutions that much. And also sometimes faith and community leaders don't know how to address, for example, certain health issues that relate to women.
Yeah, so I would agree with that. So what I wouldn't say is that faith groups are what we should lean on in terms of trying to necessarily engage. I mean, like everything, there is a time and a place, and sometimes it is the right thing to do. So I know that when we've done work trying to engage some Muslim men around cancer screening and things like that, we have engaged imams, and they have actually been able to have much more traction and much more impact than, you know, the health service, because they've been able to weave it into their sermons, be able to point to bits of parts in the Quran that describes why you need to look after yourself and things like that, and take preventative measures and things like that. So there is always. So I think it's all about, it's on an individual basis. But you're right. I think that that's the reason why we did some of this insight work. It is about trying to understand which groups of people, what types of messages, what types of people will engage the best with certain groups, because it changes by ethnicity, by age, by geography. So actually, it's not a one size fits all. And so I think if people just rely on, okay, we'll go to a faith group to support us with this, well, they're not necessarily going to be successful, because it might not be the right channel or the right mechanism to use.
Clint, what is your experience?
Yeah, pretty much the same. I mean, we've just got in the Wirral, we have 3 mosques, and we have 2 what I would call multiracial stroke BAME Christian groups. However, I think Edna's right, for certain things, we would engage with them around certain things. We engaged with one of the mosques around smears for women. The Dean Centre, we engaged with them heavily around that, and they were very useful because of the women that work in the mosque there, that volunteer, should I say, in the mosque there. We used one of the Christian groups around to advise some of our African communities on prostrate issues and sickle cell. So yeah, in some instances they are useful. However, you have to, for want of a better phrase, you have to pick your moments with them, because you have to be careful not to lean on them too heavily and leave them to it, because then the wrong message can come out. And I'm a great believer in, when working with our local faith groups, work with them. Don't just give them leaflets and leave them alone. Work with them. Bring our skill sets from the organisation to the faith group to help them deliver what needs to be delivered.
That's great. Quite a few reflections there and ideas that we can take away. A final question: what would you need from researchers? How would you like researchers to support you guys in the work that you do?
I mean, I'm jumping in here, Edna. Sorry.
No, you crack on.
What I would love from researchers is for us to highlight, look at the barriers, understand what that means to the client group, look at sustainability of services. 2-year wonders that they don't work with our community groups, and continuing to develop the service as well. You know, we've recently, a quick example, we've had a service, I won't mention the service, we've had a service from a strategic partner for 6 years, and they've only just come back to us and said, oh, right, yeah, we're going, and we've been asking them for years, year on, we need to look at this, we need to review it, we need to look at it. And they've just come back to us now 6 years down the line to review it, and don't want to change the finances around it. So basically they want more for less, which dilutes the service, if that makes sense. So what I would like is for research, a good piece of research to highlight the inequalities that are still there. I'd like us to be looking at the future. Can we foresee any inequalities that may come, particularly with what health issues that we've got on the horizon around COVID as well. Edna, would you like to add something on that?
Yeah, so I've got to jump off in a minute, so I've got to go and collect my son, otherwise I'll be fined by the nursery. So I suppose for me, it's a lot of what Clint was saying, but also to just build on some of the work that we've done recently to kind of understand a little bit more about mental health services. How can we get people from ethnic minorities to actually engage before they meet crisis point? Because that's kind of why we've got a disproportionate amount of people from, it's one of the reasons why there's a disproportionate amount of people from ethnic minority backgrounds that have been sectioned, because they don't access talking therapy and things like that. So I think that's important. I think we need to explore a little bit around the trust situation. What is it going to be? What do we need to do to get them to trust, you know, people that are delivering, that are trying to help them delivering these messages? But we also need to get a better understanding of how these communities differ, because I think quite often ethnic minorities are lumped in together as one homogenous group. So if you take Africans, for instance, people just talk about Africans. Now, I'm Ghanaian. I've got friends that are Nigerian, and I know their upbringing and their culture is very different from Ghanaian. Equally, I'm Black. But, you know, someone from a Caribbean background is also Black, has a very, very different upbringing for me and different cultures. So what we need to stop doing is treating these people, ethnic minorities, as a homogenous group. So when we talk about BAME, because I don't use that word anymore, because I think it means that it's an all catch. It's a word that kind of just talks about ethnic minorities as one group. And that can be problematic, I think. Now, I don't know what the solution is, because our research also told us that people didn't think that was an appropriate term, but I recognise why we use that term. So those are the things. So the stuff around trust, around how we better engage, mental health services and any other services that we know that they're not accessing, like any preventative screening, that type of thing. How can we get them to actually access and engage?
That's great. So you've just given me a lot of work to do, but that's great. Now this hour went very quick. I hope it went quick for everybody. Thank you so much to Edna and Clint for their comments, and to my colleagues Joe and Paula as well. And please keep in touch with ISR, because a lot of the research that is forthcoming, we will communicate through some future events as well. So thank you so much, everybody. And we shall see you soon. Keep in touch.
Thank you all. Thank you all.
Good night, everybody.
Good night. Good night.